Today we are going to discuss about the management of the chronic carotid artery disease. And first of all, I like to welcome all our speaker, panelists, and the moderator. We have three eminent speaker for today's webinar. Dr. Fali Pocha is a senior neurologist. Is working at Just Slope Hospital. We have Dr. Paritosh Pandey, is a senior neurosurgeon. He's working at the Manipal Hospital, Bangalore. He is also the secretary of the Neurological Society of India. We have a very eminent neurosurgeon, Professor B.K. Mishra, sir, with us. We have two panelists, Dr. Suresh Santla, is working at the Glen Angel Hospital, Mumbai, and Dr. Anita Jagatia. She's a professor and head of the department at G.V. Pant Hospital. Along with me, Dr. Pramod Giri will be the moderator for this webinar, and Shiv Shankar, I think, is busy with some spine surgery. He's a convener for this webinar. So, without delay in anything, we will start this webinar. Before that, I'll just make a short announcement. Like, I will request the speakers to stick to the stipulated time, so we'll have more time for the discussions. And we'll have a talk first. All the three speakers will talk, and at the end of all the three talks, we'll have experts, panelists comment, and then we'll start the question answer session. So we'll start with our first speaker, Dr. Fali Pocha. So I will just share his slides. Slides are visible? Dr.
Yeah, I think I can see them.
Yeah, okay. So
thank you.
Yeah.
Thank you. So let's start with the first slide.
Yeah, this is the first slide.
No, I mean that's just my name and the topic. Yeah, good.
Yeah, okay, yeah. Perfect, yeah.
Yeah. So I'd like to start with a few disclaimers first.
Okay.
There are many causes of carotid disease. A few of them are dissection, fibromuscular dysplasia, but today we are only going to talk about atherosclerotic carotid artery disease. Second and most important disclaimer is I did my stroke fellowship in London, Ontario, Canada, not the US. So I would say, hence, I am a little more rational in my approach to carotid artery disease. Compared to the US, I think Canada is far more balanced. When I did my fellowship with Dr. Hajinsky, we had Henry Barnett was the emeritus professor, still active in lecturing and lots of papers, even when I was there and he had retired. We had Ferguson and Barr, senior neurosurgeons, and all of them were very much part of the NACIT trial. NACIT trial was published in 1991, so you can imagine that's 35 years ago. And many things have changed, as we'll discuss in the next few slides. I also worked with Dr. J. David Spence, who was an expert, world-renowned expert in atherosclerotic carotid disease, and he was one of the strongest advocates for medical management of asymptomatic carotid artery stenosis. If you just type J. David Spence and asymptomatic carotid artery stenosis, you will get well over 100 articles on that. And he had actually shown many of the things I'll be talking about later. So, as I said, much has changed in the last 35 years in all fields of neurology, but I would say especially in stroke. When you come to acute stroke, in the time of NACIT, you only had aspirin in various doses, right, going from 50 milligrams to 1.2 grams, 625 BID. Then we had intravenous streptokinase trials, a big failure. Intraarterial urokinase, some benefit, but no proven benefit, until the final TPA trial, which showed clear benefit. Followed by, we have tenecteplase. Now in Paris, they are developing nanoparticles which go straight to the thrombus and give the drug straight directly into the thrombus. So you may not require thrombectomy in the future. Of course, thrombectomy is the proven best treatment for large artery stenosis occlusion. So we're going from time window. The NINS TPA trial was 3-hour time window, plain CT scan, and give TPA. Now we go into tissue windows. Imaging has changed from CT scan to MRI perfusion, much advanced in Doppler, transcranial Doppler, and now plaque imaging. Time is brain both for acute and preventive strokes. Early endarterectomies is far better than late endarterectomies. Stenting is, I would say, I put a question mark and exclamation marks. Is it catching up with endarterectomies or not? I think between the next two speakers, we will discover some of that. We have many new medications which we never had during the NASA trial. We have high-dose statins, we have PCSK9 inhibitors, we have clopidogrel, ticagrelor, we have GLP medications which are shown to reduce risk of stroke as well as controlling your diabetes and your obesity. Novel anticoagulants, novel oral anticoagulants are there for atrial fibrillation. Best medical practices have totally new guidelines for BP control, cholesterol control, sugars, exercise. There are now new stroke risk factors being developed. Obstructive sleep apnea is a very strong risk factor for stroke. Homocysteine in India is a strong risk factor. It was never proven in the trials abroad because I think they have folic acid fortified bread. So I don't think that the vitamin trials were very successful there. We have a new category of stroke called embolic stroke of unknown significance, where if you have ruled out every other possible cause and you have a mild to moderate carotid disease, but you can show that it's an unstable plaque, you might even advise carotid endarterectomy or stenting for that. So we must learn, as I said, both from successful trials as well as trials that have failed, because that way we know what we should not be doing. So the ACAS was the first asymptomatic carotid artery stenosis trial. NASCET ended in 91 and was published in 91. ACAS ran from 91 to 94, published in 95. And of course, we have the guidelines for symptomatic carotid stenosis after NASCET, SCET, and the veterans trials. The ACAS trial enrolled patients of more than 60% stenosis. And over 5 years, they showed a 5.8 reduction in stroke after endarterectomy, compared to 11 point something % reduction in the medical room. So approximately 1% reduction per year. You had to take the upfront risk of about 2% of having a stroke during the endarterectomy. So the graphs really only diverged after year 3.5 or after 4 years. So you really saw the benefit of endarterectomy only after 4 years of the trial. And unfortunately, many of the subsequent strokes were small vessel disease and cardioembolic strokes. So I don't believe that the ACAS was a groundbreaking trial. It had many criticisms, and we were not in Canada treating asymptomatic stenosis with endarterectomy. The ACAS showed very questionable benefit in women compared to men. Then we got to the ACST2, which was a carotid artery stenting versus endarterectomy trial. They had 1811 patients in the stenting arm and 1814 patients on the endarterectomy arm. Slightly higher, but not significant, periprocedural stroke or death in the stenting arm. The fatal strokes were 0.9 and 1.1. Again, none of these are significant. The disabling strokes were slightly higher in the stenting group compared to endarterectomy, but none of these showed any statistical difference. So there was no benefit of stenting over endarterectomy based on ACST2. Then you have the European trial, the ECST2 trial, which took patients of carotid stenosis less than 50% or equal to 50%. They could be either symptomatic or asymptomatic, but they used a score, a carotid artery risk score, where if your estimated 5-year risk was low to intermediate, that is less than 20%, then you went into either an endarterectomy with best medical treatment or best medical treatment. And both arms were the same, so there was no benefit of endarterectomy over best medical treatment. Going on to the SPACE2 trial, this was asymptomatic patients with more than 70% stenosis based on the European criteria, not the NASCET criteria. It was best medical treatment versus best medical endarterectomy or best medical stenting treatment. And the cumulative risk of any stroke, either ischemic or hemorrhagic, or death at 1 month was one of the criteria, and any ipsilateral stroke up to 1 year was a second criteria. Well, they looked at this outcome. The two outcomes were the immediate 1 month risk and the 1 year risk. They planned to enroll 3,550 patients, but they were only able to enroll a small number, 513 patients, out of which 203 were in the endarterectomy group, 197 was in the stenting group, and best medical treatment had 113 patients. The 1 year risk of major secondary endpoint, that is stroke or death, in endarterectomy was 2.5%, stenting was 3%, and best medical treatment was much lower at 0.9%, but still this did not achieve statistical significance for endarterectomy or stenting. And almost half of all strokes occurred in the peri-interventional period. Going on to the first CREST trial that was published in 2010, to symptomatic and asymptomatic patients of carotid stenosis of more than 70%, stroke, MI, any cause of death in the immediate post-operative period. In the stenting group was 0.7%, in the endarterectomy group 0.3%. The stroke risk was 4.1, slightly higher in the stenting group, lower at 2.3% in the endarterectomy group, but again, p-value didn't reach significance. Ipsilateral stroke within 4 years, again higher in stenting group, lower in the endarterectomy, 6.4 versus 4.7, but not reaching a significant p-value. Stenting increased perioperative stroke risk, mostly minor strokes. Endarterectomy increased the risk of myocardial infarction. What the trial found was that if you were less than 70 years of age, stenting was preferred over, if you're more than 70 years of age, endarterectomy was preferred for stroke prevention. So younger stent, slightly older endarterectomy. Then we have the very, very controversial CREST-2 trial of asymptomatic carotid stenosis of more than 70%. Here there were two groups, the endarterectomy group, which was endarterectomy plus best medical treatment, and the stenting group of stenting and best medical treatment. So the CAS group, there were no strokes in the medical treatment group. There were 7, this is the immediate 0 to day 44, I'm not talking about the longer one. In the 0 to 44 day, in the stenting group, there were 7 strokes and 1 death. In the endarterectomy group, there were 9 strokes. And in that same endarterectomy versus best medical treatment, the best medical treatment had 3 strokes. But the composite endpoint of ipsilateral stroke at 4 years showed that with best medical treatment, the risk was 6% versus 2.8% in the stenting group, stenting with best medical treatment, and 5.3% in the endarterectomy group with best medical treatment. So this was rather surprising that after so many years, stenting showed a benefit. But you have to remember they had extremely strict criteria for both medical therapy and very, very selected centers to do stenting. So there was always going to be a slight skew in the data. And there are a lot of criticisms of CREST-2. So is it that lies, damn lies, and statistics? If you look at the closer analysis, it shows that only 104 strokes occurred in 2,485 patients over 4 years. So the 4.2% risk over 4 years, 1% per year. Most, about 67 to 70% of strokes, were minor strokes. Stenting resulted in as many major strokes as IMM1 is the intensive medical management group 1, which was the group of the stenting versus best medical treatment. And IMM2 is the endarterectomy group versus best medical treatment. So in the virtually the same number of strokes, major strokes in the stenting group as compared to best medical treatment, 4 versus 5. And the major strokes in endarterectomy group versus best medical treatment or intensive medical management 2 were 3 strokes in the endarterectomy versus 5 strokes in the best medical treatment. So I think endarterectomy and carotid artery stenting provide similar results, but should be reserved for those who fail intensive medical management. And a global interpretation of all evidence is required when you're interpreting results like the CREST-2 trial. In the CREST-2 trial, they came very, very close to statistical significance. It was just barely significant. So I think we need a more holistic approach and a global approach to reading data when you come to trials which are very, very marginally statistically significant. These are the criteria they used for the CAR score. I'm not going to go into great detail, but they use degree of stenosis, they use near occlusion, time since the last event, the definition of the events in the CAR score were minor stroke, major stroke, TIAs, and even those definitions that, the TIA definition is up to 24 hours. Now we no longer define a TIA as 24 hours. If you have a transient attack and you have a normal scan, that's a TIA. If you have a transient attack and even a small dot on diffusion, that's no longer considered TIA, it's called a stroke. Plaque ulceration is another major criteria for the CAR score. History of MI or history of peripheral vascular disease, peripheral arterial disease, are all other criteria used in the CAR score. So the 5 years using the CAR score, if it's intermediate, that is 10 to 20%, patients with ACAS should be treated with medical treatment, and that's intensive medical treatment. So cholesterol, LDL less than 70, sugars absolutely controlled, exercise, intensive exercise, and stop your smoking, treat every known risk factor. And if you are higher risk of more than 20%, then you should consider either endarterectomy or stenting. We need to assess the degree of stenosis, preferably using NACET criteria. We need to now look at the plaque with either ultrasound or MRI. Ultrasound is very operator dependent, but in a good hand, you will get excellent results on ultrasound. You can see fibrous or a thin cap. You can see intraplaque hemorrhage. You can see ulceration. You can use the transcranial Doppler for what is called HITS, high intensity transient signals. Those embolic signals that you can pick up on TCV, even in asymptomatic patients. PET scan imaging, standard fluoroglucose imaging can pick up inflammatory plaques. They also have a different sodium tracer, which can pick up minor calcifications in plaques, but these are still research-based and not in regular practice. I think we should use all available methods to identify vulnerable plaques in cases of asymptomatic carotid stenosis. I do not believe that stenting is any better than endarterectomy, and I think we should need to carefully select patients using all best in imaging, ultrasound, MRI, plaque imaging, transcranial Doppler to select patients of ACAS to undergo either stenting or endarterectomy. Thank you very much.
Thank you, Dr. Palipocha, for an exhaustive presentations about the various trials, starting started 35 years back about the NASCET up to the latest we have about the CRESU trials and the results now. So Dr. Pali will keep the questions at the end. So now, thank you again. Now I will invite Dr. Paritosh Pandey to talk about the carotid stenting for the carotid stenosis. Dr. Paritosh.
Yeah. First of all, thank you very much for having me here. And it was wonderful to listen to a very senior neurologist who has made my job very easy. So first and foremost, before the first statement, I should say that we or at least the Americans and the Westerns treat too many asymptomatic carotid stenosis, and that is probably something which is driven not by evidence but by many other things. And we should treat a large number of those patients with best medical management. And I completely agree that the stenting or endarterectomy should be reserved only for very high risk such patients. And this is what is there. It is also very, very clear that carotid endarterectomy is the gold standard procedure for patients with high-grade carotid stenosis, especially the symptomatic patients. And this is the procedure against which almost all trials, except for a few recent trials of carotid artery stenosis, are compared, especially in symptomatic ones. Until now, it is the only procedure to be compared to best medical treatment, especially for symptomatic. And now we've learned that CREST2 and ECST2 have compared it to best medical management itself. In the US, 150,000 endarterectomies are performed every year. And this is a very, very large market for the endarterectomies as well as for stenting. And hence, there is a large number of trials which keep going around for both endarterectomies and stenting. And almost 80 to 90% of these procedures are for asymptomatic patients. And this is post ACAS and ACST2. And I'm sure that the CREST2 data, however problematic, will go ahead and make this even more robust, not just in the US, but in many other parts of the case. As is there will always be a lookout for a procedure which is less, quote unquote, less invasive. Just as coronary artery stenting was there is carotid artery stenting. And it has been subjected to a fairly rigorous and extensive scientific scrutiny. And a large number of trials have compared endarterectomy and stenting both in symptomatic and asymptomatic patients. And this has been there has been fair amount of scientific scrutiny for stenting, so much so that even now the Medicare, the CMS does not recommend endarterectomy for low risk patients, even after so much evidence, and there is there. But any trial before the advent of modern hardware should be considered historical. As with surgical procedure, there is positive relationship between higher operative and institutional volume has been shown in many patients. And many techniques like EPD use, balloon sizing, dwell time, patient selection are very important determinants of avoiding periprocedural complications. We know that endarterectomy results have become better in the last 50 years. So if from 1970 to Act 1, the results have become from 11.4% to close to 1 to 2% of stroke and death risk in these patients. So the endarterectomy results have become better because of the surgical thing, because of the periprocedural management, because of blood pressure management, because of antiplatelet, statins, all these things. Similarly, carotid artery stenting also has improved by a large amount. So what used to be 9%, 7% periprocedural risk that we used to do, even in patients in 2005-10, is now down to 2 to 3% periprocedural risk, and this is there both in symptomatic patients. So if you see CREST2 registry, there is still 2.8%, which is a mixture of asymptomatic and symptomatic, but the results have become better in symptomatic. And of course, the results have become very good in asymptomatic patients. So in asymptomatic patients, we generally quote the stroke death risk of 1 to 2.5% in most of these other things, as is there. As with the endarterectomy high-risk features, there are stenting high-risk features as well. So anybody over 70 years with a large amount of plaque in the aortic arch, severe aortic stenosis, high-grade aortic arch, type 3 arch, those kind of things, are unable to use EPD, and we'll come to that here, or thrombus there. So those patients are high risk for CAS, just as we know that there are high-risk features for endarterectomy as well. So absolute contraindication, of course, there is if there is angiography contraindication or luminal thrombus or occlusion, or patients who have other intracranial vascular malformations and other kind of things. Lesions with significant calcium burden are also not ideal for stent placement, and 360-degree calcification on CT angiogram is a contraindication. Also, if there is 2/3 circumferential or more than 3 millimeter thick solid exophytic lesion, then they are also not very good. This is a patient who was a relative of one of the intervention neuroradiologists, and she had multiple TIAs, no stroke, and had significantly calcific lesion. And we went ahead and did this, and I'll show you this very quickly because the sir will show something. But you see the thickness of plaque. It is very difficult to cut through the plaque with a scissor, and the entire thing is very calcific. And these are very, very poor patients for stenting, and these should not be done. So, and I'll skip this video later. When should it be done? It should be done after 48 hours, but before 14 days. And this has been in guideline forever. And once the 28 days pass or 30 days pass, generally the risk reduces to as low as asymptomatic patients. So if you have to do it, please do it early for symptomatic patients. This is the general preparation, dual antiplatelets. So 5 days, complete angiography. The steps are simple. It is not a very complicated procedure. We have vascular access, either femoral or radial. We do an angiogram. Then we place a guiding sheath, which is 8 French in most cases in common carotid artery. We cross the lesion with wire and place the embolic protection device. We pre-dilate if needed. Then we place a stent on the wire itself. All of them are monorail, which is basically one operator can go ahead and do it. These are all self-expanding stents. We post-dilate if necessary. Then we capture back the embolic protection device, and then we do a control angiogram. So this is a very string-like carotid stenosis. We cross by the wire, place an embolic protection device here. Then we place a stent, and then we do a balloon angioplasty. You see a little waist here. So we do a balloon angioplasty and achieve a fairly good result here. Wire is used to reach the far end of the vessel, to rail the devices into the carotids, to access the lesion, to cross the lesion atraumatically. So we can either use the usual neuro wires like hybrid or other things, but if the patient has if the lesion does not cross, and there is calcification or the plaque is very thick, then we may have to use coronary wires, and sometimes we have to use CTO wires as well. So in those cases, we use the BMW or run-through wire in these patients. Of course, pre-medication is there. Ideal to start with dual antiplatelets with aspirin and clopidogrel. If it will not be started, then we can load it. Generally, right, common femoral artery, sometimes radial. I don't do radial, but many people do radials, and the arch is then cannulated here. There are 3 types of embolic protection devices here. One is the distal balloon, one is proximal balloon, and one is the filter. Most of the patients that we do is by filter, which takes the debris and captures it into the debris. It's like an umbrella-like device. But there are MoMA devices which occlude common carotid artery and external carotid artery, and then there is no flow across here, and then there is. I will come to TKR later because that is another principle. It's there. These are sides of the filters, and these are the various companies give this thing. An appropriately sized EPD is selected and placed. It should be placed in the straight terminal segment, and post deployment angiogram is for check adequate opposition to the arterial wall. Is it mandatory? There is no very large trial comparing with EPD and without EPD because the number of patients are very low. There is a small trial where there is no difference between whether we use embolic protection device or not. But this is a small trial with 279 patients only. And which EPD to be used? So proximal balloon deployment is superior to distal filter or distal balloon. So proximal balloon is probably a little better, but there is no difference in the neurological status in all these patients here. And there are other single center devices experience which show that it can be done without protection device. And if they are not recently symptomatic, or if there is no ulcerated plaque, then probably yes. And we do a few of them without thing because it cuts down the cost. But if you see large registry, then the Americans have found that not using EPD was associated with higher in-hospital mortality and worse outcome, as was seen in this patient as well, where they showed that it is associated with 4-fold increase in likelihood of perioperative stroke here. But this is one patient that we did without filter. So that was the carotid stenosis. We are taking control angiogram before. We go ahead and cross it with a wire, and then go ahead and do a pre-plasty with a 3 mm balloon, and then put a stent. And many of these patients do not have any clinical significance. We don't do DWI lesions for most of them, and we'll find a few DWI lesions in a lot of these patients. but that is probably clinically non-significant here. Then we do pre-dilate and with a small balloon. All of these are mostly coronary balloon. Wire track is a good balloon with usually 2 mm balloon, 3 mm balloon, maximum of 4 mm balloons, so that the stent can go and get delivered. Stent is a little bulky and it needs space to go and do this. There is disadvantage that there is risk of distal embolization. So that is done if we are placing then after placement of EPD. And it is a monorail over the wire, a 0.014 compatible balloon or low profile coronary balloon. When we do this, we keep atropine ready because this can cause severe bradycardia. So some people also preload the patients with balloon. Carotid stents are of 3 types: open cell, which is Acculink or Precise; closed cell with exact or wall stent; or dual layered stent where there is a mesh covered on the stent itself. And it is based on presence or absence of continuous connecting struts of the ring of the stents. Open cells are maybe better in angulated vessels, but they have larger free cell area and there is a larger embolization. But closed cells are used in patients who have soft plaques and things. So these are how it is there. So if you want more flexibility, open cell. If there is a lot of tortuosity, then probably open cell stents. But if there is less tortuosity, then probably closed cell. Nowadays, we have C-Guard amongst all these things: Road Saver, C-Guard, and Gore. So we have C-Guard in India. And head-to-head comparison has not been done. But in patients who have we are using during stroke, or we are not using embolic protection device, then probably dual layer stents are probably better. So this is what is there. Open cell has higher flexibility, but higher plaque prolapse risk. Closed cells are less flexible, but lower plaque prolapse risk here. Then the stent diameter, most of the times we use 6x8 taper stents. So 8 millimeter stays in common carotid artery and 6 in internal, or 9/7. And usually 30 to 40 millimeter stents are okay. And these are deployed under fluoroscopic guidance. We can use vertebral body as landmarks. We can release 2 to 3 millimeters and then do an angiogram and see. And then we post dilate. So post dilatation is probably one of the is the time when there is maximum embolization happens. And if the thing looks okay, then we don't post dilate. Otherwise, a high pressure balloon around 5 millimeter, and then we go ahead no larger than 5.5 millimeters. And if there is 10 to 20% residual stenosis, that is very acceptable. There is no problem. And if we have done EPD, then we have to remove those things. And it is done. Sometimes it becomes complicated because it gets stuck in the stent itself, but most of the times it is an easy procedure. So this is one of the patients who has previous CE and had restenosis. We did not want to operate. And this is the successful stent placement. Another patient who has another video where there is a ulcerated plaque. We go ahead and put the embolic protection device over the wire here, and then pre-dilate this with a balloon, and then go ahead and put a stent. All these are done under conscious sedation. Almost all these patients are done under conscious sedation. So there is continuous monitoring. And there is another patient who had right side severe stenosis. And this is a patient here. This is a little distal to the bulb itself. This is in common. This is the placement of the embolic protection device. Pre-dilate with a balloon. This is after the balloon, and then we go ahead and put the stent here. All of these are conscious patients, so there is some movement sometimes, and then we go ahead and post-dilate with a balloon. You will see that patients are moving, but once we get to different things. Post-procedural care, blood pressure is very important. Systolic blood pressure less than 140. Aspirin clopidogrel is used for 30 to 45 days, after which you can easily use aspirin only unless it is indicated, and ultrasound follow-up itself. There is complication, minor embolic event, puncture site complications. Major embolic strokes, hemorrhage, and acute stent thrombosis are fairly rare. This is a new procedure which is called TCAR, where we take access inside in the common carotid artery, very close to the clavicle. And then what we do is that we put a flow reversal system into the femoral vein. So blood is sucked out from this catheter and circulated through the femoral vein, and then with a filter, and then circulated back into the system. So then there is no chance that there is emboli can be done. Emboli can go into the brain, though there has been complication rate itself. Excellent results, but has been used mostly in asymptomatic patients. And these are preliminary results where the results look very good, 1.9% stroke death risk. But as I said, most of these patients are asymptomatic patients, and a large number of patients who are doctors who are using these are either vascular surgeons or cardiothoracic surgeons in the US. As per CEA versus CAS, we have done a lot. I think, in my view, after serving through all this data, all the data except that after the pre-procedural time, which is 30 days, the long-term stroke prevention risk is completely equal. So there is, the only problem is in the first 28 days or 30 days, where in symptomatic patients, this carotid stent group has a little higher complication rate than this. As I said, results of both are improving. So symptomatic CEA is better than CAS in patients with more than 70 years. It is equivalent if MI is considered. It's equivalent if major strokes and death. So difference is generally in minor strokes and not in major or fatal strokes. And DWI lesions are, of course, more than CAS, which is there. In asymptomatic patients, they are fairly equivalent, as it is there in the with best medical treatment as well. So these are the various trials. And even in CREST trial, if you take only symptomatic patients and only stroke death, then any stroke death, then CA is better than CAS. But if you take the primary endpoint, which is stroke death MI, then they are equivalent. In ICSS, of course, the CAS had a better worse outcome than this, but the argument is that most of them, or at least quarter of them, did not have embolic protection device, and many of them, there was large number of complications from one center, almost 11 complications from one center, and all those things are there. And this is for asymptomatic patients. So as Sir has already said, most of these patients, most of these data is equivalent. So almost all of them will say that the CAS is as good as carotid endarterectomy. These two are the new trials, as Sir has already pointed out. These are two trials, parallel trials, where there is a stenting trial, best medical management versus stenting and best medical management, and endarterectomy also. I should point out that the criteria that they used in best medical management is okay to use in the trial population, but looks very difficult in the real world scenario. So in the real world scenario, all best medical management or medical management is probably has worse results than the trial group as well, because you have to continuously monitor. The LDL should be less than a thing, the sugar should be less, and all these things, which are ideal but may not be achievable in a real world scenario. So as we know that the endarterectomy and stenting results are probably worse in the real world scenario, as that is probably the same case as in the best medical thing as well. And we have these things in the 0 to 44 days. And then also after some time, there was statistically significant difference, small, but it was there. They achieved that p-value which is desired in the stenting group, but did not achieve it in the endarterectomy group. And this was mostly a very, very statistical jargon. But as it happens, it is a data that is randomized controlled trial, so it will be accepted in a large part of the world. And then ECST is probably a better trial, but there is very smaller numbers. So there is 214 patients with best medical management, out of which 10% did undergo ipsilateral revascularization in the follow-up, and then 214, out of which most of them underwent endarterectomy, and they did not have initial revascularization procedure. And the results are same in all three groups here. So there is no major difference in OMT alone or OMT plus revascularization. These are interim results, and the results will come after 4 or 5 years. The results will also get published here. So this is what is there. One special group is the stenting during mechanical thrombectomy itself. So this is one of these patients which is there, a 68-year-old male, hemiplegia aphasia, and this is the patient. And there is carotid stenosis here, you'll see, and then there is MC occlusion. And then we go ahead and we angioplasty this, get the revascularization done, and then go ahead and put a stent here. And in general, what we have seen is that putting a stent is better than keeping the vessel not open. So generally, we tend to stent these patients and load it on table itself or use a GP2B3 antagonist. So this is the one. Also, I should show you that in a large number of patients or in a significant amount of patients, the ECA gets blocked in these patients because the stent pushes the debris into the EC and that gets blocked. But in majority of these patients, they are completely asymptomatic. And this is the CT after some time, and he was MRS1 at 90 days. And then another patient who had tandem occlusion, hemiplegia aphasia. This is the CT scan. This is how we find the carotid is completely closed. We pass it through a wire and angioplasty it with a balloon here. Then we see that the MC is also occluded. These are called tandem occlusions. We go ahead and revascularize this. And while coming back, we see that there is significant stenosis. We angioplasty it, and then we go ahead and stent this vessel. And that gives fairly good result here. And this is the post-op scan. Then another such patient, angioplasted with balloon, went ahead and did the mechanical thrombectomy. And then while coming back, we waited for some time. We did not put a stent at that point of time, but the ulcerated plaque. And then we go ahead and put it after loading them on antiplatelets here. So as with endarterectomy, and stenting has undergone tremendous evolution. It continues to be subject of much debate and scrutiny. In asymptomatic patients and in low risk symptomatic patients less than 70 years, stenting is an equivalent procedure to CEA and should be offered to patients as a choice itself. And of course, more data will show that best medical management is equivalent to a lot of patients in asymptomatic and low risk symptomatic patients. And many of these patients probably will be treated with only best medical management and none of these other procedures. Thank you very much.
Thank you, Dr. Paritosh, about an excellent depiction of various procedures being performed for the carotid stenosis, mainly in the form of the interventions. Thank you again. So now we'll have a surgical role in management of the carotid stenosis. I will like to invite Professor Dr. Basant Mishra, sir. He's going to talk about carotid endarterectomy for a carotid stenosis, sir.
You seeing my screen?
Yes, sir, we can see.
Oh. Okay. So I really enjoyed the talk of Dr. Fali Poncha. It's a beautiful talk. I wish more neurologists are like him. And Paritosh was a very balanced talk. The only one comment before I go on, saying that the less invasive, I'm not sure if it is less invasive. The stenting, I think, is more invasive than the endarterectomy. Is such an easy procedure. The only difference is there is a cut and there is no cut. That's all right. But otherwise, I think it's less invasive to my mind. I have nothing to disclose. I just want to, my talk is trials and the truth. Because there's just the very recent two articles which has been retracted. One is from NEJM and one is from Lancet, the best medical journals we read, and the evidence which we follow. And so there is tremendous amount of pressure to publish, editors having pressure to publish, industry pressure. So one has to be very careful about taking this data. So I don't want to go through this. Very nice summary by both of them. This is showing that over a period of many years, half a century, that the endarterectomy has been found to be better. I'm talking only of symptomatic carotid stenosis. In my practice, I do not offer any intervention for asymptomatic carotid stenosis. That's probably going to change because the neurologist will probably do it, but I don't do. If a patient comes for an opinion, I don't advise it. Just Dr. Paritos talked about that in a trial setup, you can have that best medical management. But please remember, both the arms had the best medical management. So the groups who had the intervention, whether the endarterectomy or stenting, also had the best medical management with same kind of vigor. So I think that to that point, it doesn't make any difference. And Paritos has already said there is actually no randomized trial of stenting versus best medical management in a symptomatic carotid stenosis as of today. So there are many trials. The EVAS was stopped because the stenting was worse, much worse, and significantly. Now I just want to show you this. This is the Lancet, the ICSS in 2010. What they said is carotid endarterectomy should remain the treatment of choice for patients suitable for surgery. And this is Lancet, okay? Same, after 15 years, same study, they came out, long-term functional outcome, same study, fatal and disabling stroke. Because the goalpost change. You see, this is industry pressure. I think this is an industry pressure, nothing else. Because previously it was all stroke. Now they said, we can't find any difference. It's worse. So let's do something else. So that is statistic jargon. Now, this is CREST. Of course, the first one, of course, said that the stenting is worse than the carotid endarterectomy. But again, the CREST, then they started off symptomatic carotid stenosis. Trial started as a symptomatic carotid stenosis treatment. But in the halfway through the trial, they started including asymptomatic, and 47% of the total were asymptomatic carotid stenosis. Myocardial infarction was a primary endpoint, not in other studies. Now, what we treat the carotid endarterectomy? Carotid stenosis is treated for strokes, not for MIs, right? But MI was defined in their study as enzyme elevation with chest pain, ischemia. These are not infarctions, it's minor strokes, everything was MI. But the minor strokes, which is shown in MI by MRI with the diffusion restriction, was not included. So there is, a lot of trying to permutation combination to get it the right combination to, so that the carotid stenting is as good as the carotid endarterectomy. Now you go more deeper to these data. The peri-procedural in the carotid stenting, the twofold higher risk of stroke, twofold higher risk of death, 50% less MI. So that the MI less, that became they became together same. What was the high risk of MI in endarterectomy? Because the difference in the antiplatelet therapy. In the stenting group, there was always double antiplatelet for 30 days. In endarterectomy was single antiplatelet. Probably this is the only cause, the early MI in the peri-procedural MI in the CA group. Now, if you go further, at 4 years, 2.5-fold increase of MI in the stenting group than in the endarterectomy group. Never been, not included as the endpoint. So if you read only the abstract, it comes out as if for younger patient with a symptomatic carotid stenosis, the CAS is probably better. And that's what, in fact, many neurologists I have talked to, they think that is not true. The only true, I'll come to that. So peri-procedural symptomatic patients, twofold higher risk of stroke and death in stenting. Asymptomatic patients, nearly twofold higher risk of stroke. These are all in stenting. Women, 2.5 higher risk of stroke. Above 65 years of age, twofold higher risk. All these are significant. The only patients who did better than the endarterectomy in the CREST-2 is asymptomatic males less than 65, not 66 symptomatic. Many clinicians, both neurologists and neurosurgeons, believe that it is younger patients are probably better with stenting. Not true. It is only asymptomatic. Go through the detailed data and you will find this. So those are the statistical jargon. What about the meta-analysis? Now, these are older data, and Paritosh said things are improving. I agree with that. But the data stays that in the meta-analysis is a very strong evidence. These are some of the meta-analysis favoring earlier data, but published in Lancet, and this included CREST. And you see this is all favoring the endarterectomy was better. Now, the Cochrane review, you see the risk ratio, and what did they found? Within 30 days of treatment, stroke and death rate was much higher in the stenting group, highly significant TIA, highly significant high risk, restenosis at 1 year, highly significant, follow-up stroke and death rate, significant, at 10 years, highly significant. All worse. This is Cochrane 2015, I think. 20 Cochrane 2020, stenting for symptomatic carotid stenosis is associated with higher risk of peri-procedural stroke or death than endarterectomy. And just because this audience probably a very, very knowledgeable audience, I'm just going through some of the data. Now, before the CREST-2 asymptomatic data, most of the data suggested, and I agree with that there is, in fact, very little justification of offering any intervention for asymptomatic, unless very, very select group of patients. But even if you see carotid stenosis asymptomatic, there also CEA does better than CAS. This is another 2017, 9 randomized controlled trials. Again, everything favors endarterectomy than stenting. Now, this is the last one, of course. This is 2025. We have already talked about it extensively, so I don't want to go more to that. The CAS was statistically better than best medical management. But please remember, there was one death in the first 44 days. There was no death in the endarterectomy group. Revascularization ICH higher in the stenting group. Now, this is one of my residents I said, just find out any recent data. So this is in, I think, 2025. It is 2025. CAS reduces the risk of myocardial infarction and cranial nerve palsy. It is associated with higher risk of stroke and restenosis compared to CA. These findings, I suggest the importance of individualized treatment decision based on patient risk profiles. An urgent management of symptomatic carotid artery stenosis, a review of the literature. In conclusion, our study reinforces, again, 2025, the importance of early CA. We all know that within the first 2 weeks of symptomatic carotid stenosis, aligning with strong evidence that surgery within 14 days provided the maximum stroke prevention benefit. So I'll just give you some of the institutional reports. Again, most of the data before the CREST-2 and the asymptomatic suggest that the endarterectomy is better for symptomatic severe carotid stenosis. Now, this is a cartoon showing the 2 different procedures. Now, what do you do when your drain is blocked? You like to clean it, right? You don't want to put another instrument inside. What do you do? In spite of all the various mechanisms, you're still pushing some, and you're still having a higher risk of diffusion, restriction, and stroke. And to my mind, enzyme elevation MI, cardiac disease, is much safer than a stroke, which will manifest over a period of time with cognitive deficit. It's a very short video, but I think if they're a neurologist, but this is just to highlight the fact that Paritosh showed a very nice video. These are thick, sometimes very highly calcific, but otherwise there is calcific, and just putting in anything inside that, just counterintuitive to me rather than taking it out. Yeah, it's a very simple procedure. Anybody who is, reasonably good surgeon, you have to have, of course, good perioperative management, good anesthesia technique, and so on. But you do that, and this, I think this is not the thing to show, just to show that you take it out, you have a clean carotid intima there, and then you close from both sides, you back bleed, and the routine procedure. I don't want to go through that details, but this is a surgery procedure which takes about half an hour to clean it up. the whole procedure takes longer time, but we don't worry about that. We do not, I mean, out of 100 cases we analyzed, only 3 patients we had to put a shunt. So it's very unusual so that we need to do it. And we usually 6-so-proline. And this was one of these cases. And this is my case report, series, which we published in Neurology of India in 2009. This is probably first series by neurosurgeons. There had been series before by vascular surgeons, but there in India, unfortunately, there was never been, kind of published by neurosurgeons. We had out of 130 cases, I think this one, 2 patients we had lost. First patient was the second in the series. Seconds for secondary to MI on table prior to carotid manipulation. So we realized that patient has to have a complete carotid cardiac evaluation by a cardiologist in-house cleared before we do it. Otherwise, we don't do it. We send it for stenting. Second patient died of pulmonary embolism. This is of 130 patients. And so we had a mortality rate of 1.5%, stroke rate of 1%, and MI of 1%. This is the Cochrane data. I think we compare well with them. Population-based clinical studies, you see this is vascular 2017. In-hospital mortality, highly significant excess in stenting compared to endarterectomy. And this is very large data. This is hospital population. In-hospital stroke rate, significantly higher in the stenting group. There are, of course, unique indications. In my practice, if the patient has a severe coronary disease, unstable angina, recent MI, they are candidates for stenting. We don't do that. Poor candidate for GA, technical, very high bifurcation. We used to do it that earlier, used to mobilize the mandible. I don't think it is justifiable to do that anymore. If it is very high, we would send it for stenting. Post-endarterectomy restenosis, much more difficult to do it. I think today I would send it for stenting. Patients who have got radiation or radical nail dissection, they are better candidate for stenting because obviously you don't want to go through scar. And severe contralateral stenosis, I have a series of patients which I have operated, but I think they are safer because there is a risk of, the low kind of paresis, better to go for stenting. There are many ongoing trial, but Paritosh and Dr. Fali Pocha has already gone through that, so I'm going to skip that. I just took out those slides because there will be duplication. But to conclude, I think CA is a safe with good protection for ischemia, is a proven beneficial long-term outcome with multiple well-planned studies compared with best medical management. Is cost-effective and superior to carotid artery stenting in many, many studies. Now, this is one of the very few neurosurgical procedures which has stood the test of science. There are very, very few surgical procedures which have been, kind of stood the test of science, and this is one of such. So I cannot understand why do we have to do one study after another, when only one study, the ISAT, changed the whole paradigm, because the false sense that giving anesthesia is probably worse. I don't think that is true, because this is a simple procedure. You are treating the cause, you are taking out the offensive material from inside an artery, which is logical to me. It's cost effective in countries with less resources. I think this is the way to go. Most carotid, I already talked about it, most carotid stenting studies compared with CA only. It cannot be compared because it cannot be compared ethically, probably not correct to compare stenting with medical management in severe stenosis. Why? Because carotid endarterectomy has shown that intervention is better than medical. That's the only thing which has been shown. The carotid artery stenting has never been shown for symptomatic carotid stenosis with medical management. The critical thing is I lost my second patient before I could even start the carotid incision for the carotid surgery. So detailed carotid evaluation is mandatory. Every single patient of mine has to be cleared by in-house cardiologist before if there is any doubt, if there is unstable angina, bad disease, I would not hesitate to send them for stenting today. So this is the editors of the Lancet and the New England Journal of Medicine. Pharmaceutical companies are so financially powerful. They pressure us to accept paper. This is by editors of NEJM and Lancet. So that is something. Thank you very much for your attention.
Thank you very much, sir, for the detailed and critical review about this subject and comparing the carotid and adectomy and the carotid stenting procedures and how to select these patients for the procedure. So again, thank you. And now we'll have comments from our panelist, Dr. Suresh Sankla.
Can I just ask one question, Batuk, before
Yeah.
you go on?
Yes, sir.
I just want to, if Dr. Fali Poncha is still there or he's left?
I'm here.
Yeah, he's there. Yeah.
Okay, Dr. Poncha, I just have one question. I mean, I loved your talk, but this is the one, the common, kind of everybody's conclusion that younger patient for symptomatic stenosis, stenting is better. Where is that data?
Not better, sir. Equivalent. There is
No, I mean this is now the recommendation. Many clinicians, neurologists, neurosurgeons. No, the reason for that is there is the overall data suggests that, but it's not true. It's only asymptomatic stenosis, younger patient, the stenting was better. All other groups, including young patients with severe stenosis, the endocrinum was better. Go to the detailed data. I mean, I have spent hours and hours to study that because I'm a hawk. I'm a hawk for endocrinum. But I just want to know from Dr. Poncha, Fali Poncha, because he's a neutral guy. I mean, he's a Canadian trained neurologist, and that's very good because there is very little bias for them. But where is the data? I would like to know, correct myself.
I think it is for younger asymptomatic patients.
Sorry?
I think it's for, as you said, for younger asymptomatic patients.
Absolutely. This is younger, less than 65, asymptomatic patients, carotid. But what has happened is, these asymptomatic people have forgotten about it, and the younger has stayed. So you also said that for younger patients and many neurologists, colleagues of, friends and colleagues and neurologists, they have that kind of idea. For younger patients, stenting is worse than endocrinectomy because the long-term restenosis across studies has shown the higher rate of restenosis. So I think that's a misconception. Thank you. No, I just wanted to clear from Dr. Poncha.
Thank you, sir.
It is
Dr.
just
Suresh?
it is just one group where we have seen in the literature that the results are equivalent and not better, and that is this group, asymptomatic younger age group. But Fali, your presentation was superb, and we really loved all those statistics which you have shown in your various tables and all that. And I agree with most of them, and it was very moderate kind of presentation. And as Dr. Mishra shows, the difference was in between the best medical management as well as the intervention. And the group which has shown some improvement or equivalent result was the asymptomatic group and not the overall group of carotid artery diseases. And that is what you have to really show in your papers and in your results and all that. And I was very surprised with that also. But otherwise, the paper was fantastic, and we had a good, discussion, and the presentation was very good and all that. What I have not understood is, one thing. One thing is the best medical management. Dr. Fali, you have consensus about the best medical management, or this is also controversial? Can you tell us about the best medical management in brief, please?
I think LDL cholesterol less than 70, preferably around 50.
Risk factors.
BP management not more than 130 systolic.
And that is what is
sugar
followed in
control.
all. Sorry, go ahead.
Very tight sugar control, strong exercise, which is why it was very difficult to replicate best medical treatment in real practice. Because it takes a lot to do that best medical treatment.
All right. Yeah, very good.
My question to Dr. Fali is the recently newly evolved anti-coagulant medicines like apixaban or Xarelto has any role in aggressive medical management?
Not for atherosclerotic disease, not for atherosclerosis. You would use newer antiplatelets, newer statins, newer PCSK inhibitors, but not anticoagulants for carotid disease, not for
Even
atherosclerotic disease.
okay, even
Not
for intracranial diseases, intracranial symptomatic
no,
atherosclerotic disease.
no. Your data right from WASID has not shown to
Okay,
be any benefit. And
okay,
WASID is a long, very old trial.
okay.
Fali, this is Suresh. Is there any new trial going on which will highlight or is going to highlight the results of all three modalities? Anything else is coming up? Fali?
I'm not sure the exact name of the trial,
Mm.
but I would have to look up for anything. I think there's something you mentioned, right,
Yeah.
Paritosh?
ECST is going on, sir. So
Yeah,
ECST2
ECSC
is
is still
going
going
on.
on. ECSC is still
Well,
going on.
that's
Right.
the most interesting thing, Suresh. The
Yeah.
trials keep on going on because
Yeah. Never ending, yes.
never ending, because they have to prove
Pick up the
somehow
box, man.
that, because most trials
I feel like
till now are showing that, see, for symptomatic at least, and asymptomatic, very little advantage, very little effect at all.
Absolutely.
So that has to be changed. That is the problem.
Sir, one question to Mishra, sir. I just saw your procedure of endarterectomy where you have just removed the plaque and the vessel has been sutured. But many surgeons prefer to put Gore-Tex patch. So, is there any advantage of using Gore-Tex patch
I
to prevent
have
restenosis? Or
no. See, the most people who have used the Gore-Tex, historically, are the vascular surgeons. See, the vascular surgeons never used a microscope. So if you're using a microscope, there is very little use for, unless it's a restenosis. We have only, out of the now about maybe not very high, but around 170 odd cases, we have only used twice for once Gore-Tex and once venous patch. So our restenosis rate is very little. So it is overused mostly by vascular surgeons, and these are not microsurgical procedures. They either do loop or nothing.
Shashank, this Gore-Tex is used by the cardiovascular surgeons very often and very less frequently by the neurosurgeons. For some reason, yes. Paritosh, fantastic presentations, and you did a very good job in showing everything and all the designs of the new equipments. Is there anything else coming up as far as the devices are concerned? New.
I think TCAR is a fairly good procedure, but it is very cumbersome. And if you're going to put it doesn't make sense to just if you're putting an incision in the neck, you might as well do a endarterectomy. What I want to say is also that despite all these other things, and I offer endarterectomy to every single patient of mine because I love that procedure. The patient acceptance of carotid artery stenting is so much more than endarterectomy. And that is why the maximum number of endarterectomies that any neurosurgeon would have done is probably 200 or 300. But a rookie interventionalist is going to do 100 a year. So the patient acceptance is also something which is I tell them that the post-perioperative stroke death risk is twice in stenting group than endarterectomy group. But many patients choose stenting, and this is just something which is there. It is not, it may be industry driven, but it is not exactly industry driven. Many patients would like a stent, just as coronary artery bypass graft has a better long-term result than coronary artery stenting. I mean, it's there, the grafts are more there, but the paradigm has completely changed in this thing. And even though endarterectomy will remain a superior procedure than stenting in majority of the patients, but the patient acceptance itself is so much more for stenting. And I say this as somebody who genuinely offers endarterectomy to all the patients.
Yeah.
But almost half of the patients or more choose stenting.
Agree with you. I think the no-cut concept plays a role besides the other factors.
But then there's a chicken and egg situation, right? If the surgeons get less patients, they're going to have less expertise. I mean, your expertise goes up with the number of endarterectomies you do every year. In fact, most centers abroad will not take surgeons below a certain number of procedures per year.
Yes.
In any of the trials, you have to show that you're doing so many procedures per year to qualify for that.
Yeah.
Yes,
Yes.
correct. You're right, probably.
Yeah, yes, actually, if in the trial itself, the intervention is much more controlled than the surgery. So if you see the American trials, their credentialing of interventionalists is much stricter than the surgeons itself. So they would have to do 100 procedures, proctored, and everything is managed. So
Yeah,
at least
number
in
of
the American
procedures
trial,
number of procedures
in
they
the
have to do
American
more.
trials, the credentialing of the interventionalist is much more stricter than just a surgeon.
Yeah,
And
but
that was there in
Parithas,
ISAT as well. Yeah.
Parithas, they have to do that. Otherwise,
Yeah, yeah, of course. Yeah.
that is the problem.
No,
In
I don't
industry.
disagree. But I just wanted to say that the patient acceptance is very high for these procedures. Even if you
I think
give them very honest choice, and I swear
yeah,
I
but
give honest choice to
I
most.
think the people who can and who would be able to change that is people like Dr. Fali Poncha, the neurologist. He's not the neurosurgeon. I mean, most carotid disease patients would reach a neurologist. So it's not the neurosurgeon who is going to be the first. Not unlikely to be the first guy. It will be the neurologist. So that the neurologist has to be kind of comfortable to send it to a person who has acceptable results. I mean, if he's screwing up all the patients, you will not get you will not send it. That's the problem.
Yeah, eventually, we need to have the best judges, a person who can judge the procedures and the value of the procedures and its utility in the long run. Anita, any question?
Yeah, sir. It's a wonderful discussion which was happening, and like all the speakers were really great, and I really liked the talk of Dr. Misra because he critically evaluated all the trials, and he's right that when you're requiring trial means that treatment is still not acceptable 100%. So the trials are keep happening on the stenting group and of course on the medical management also because we do not have exactly all the drugs which will save you from the TIAs or the ischemic strokes from this. But I'll definitely say that now, for the carotid webs, the stenting is the only treatment, and carotid webs occur in the young age group, and that is because of the fibrous dysplasia and maybe iatrogenic also. So there the carotid stenting plays the role, and of course. For what Dr. Fali was telling about nanoparticles, I think that may be the future because what Dr. Misra was saying, of course, endarterectomy is the best procedure, and many patients you are not able to convince to the patients that they will go for the endarterectomy. They definitely choose for the stenting. It is not invasive. It is not less invasive, the endovascular procedure. It is rather more invasive, but the mindset is there in the people that you will get the incision. But of course, endarterectomy has its indications and stenting has its indications. And in India, actually, we do not care about the indications. That is a big problem. And as we are seeing the young generation, they are moving more towards with the stenting than the endarterectomies. So that is there. And maybe nanoparticles, which Dr. Fali was saying, I'm not aware that we can take those nanoparticles and we can just take the catheter and we can liquefy all those parts, all those plaque which is there, whether calcified or not calcified. So that may be the future. But I just want to ask Paritosh that do you do any imaging to decide intraoperatively putting the stent for stroke cases? Like, because there are some indications where you can put on table or within 72 hours of the stroke, the stenting. So do you do the MR in all the cases? Like, how do you decide that you are going to put the stent apart from the stenosis which you are seeing? Any other parameters which you are looking for?
For acute stroke?
Yeah, acute stroke with
For acute stroke,
with
yeah,
a
I mean, there is very little time for doing an imaging after the revascularization. So what we generally do is we do a balloon angioplasty and wait for 10-15 minutes. And if we think that the carotid is going to close again, then we put a stent without any problems. In our experience, the bleed rates with is not very high. And it is generally seen in the literature as well that an open vessel during a stroke is better than the closed vessel, even though it can increase the bleed risk by a little percentage, but it is better. So we don't hesitate in putting a carotid stent during that procedure. If the vessel is quite open and it's not closing down, then probably we leave it alone and then do an endarterectomy after a couple of days or 3 days, based on the Doppler result after some time. But now we are not
Because-
squeamish about putting a carotid stent during the initial acute stroke procedure.
Because you're loading with the antiplatelets also, along with the thrombolytics and all,
And
no?
many of these patients have IV TPA as well. But even
Yeah.
then, if they don't have a big stroke, they're quite okay.
That's really good, and we need to do more. I think we need to collect big data on this, and then that is really required.
Yeah, these
That's-
patients are rare, of course, so that should be, yeah.
Yeah. Anything else, Dr. Anita?
Yeah, nice.
So
Thank you.
thank you, Dr. Suresh and Dr. Anita. I want to have a questions for Dr. Fali. Like now, many times we have patients who presents with either a TI or a minor stroke, and when we do the imaging, we see almost like complete occlusion of the carotid artery. And now we are also seeing the reports like people trying to open the arteries. I'm not talking about the acute condition, but the chronic arterial occlusion, people are trying to open this completely blocked artery. What is your opinion about this?
No, I would not open a completely blocked artery.
Yeah, why I'm telling, because now, as we have discussed, and Dr. Mishra was telling about the neurologist perception about this management of this carotid stenosis. And now more and more neurologists, along with the radiologists and the neurosurgeons, are doing intervention. And I know people who are practicing a neurology practice, and they are trying to open. And even though there are international reports are available, people are trying to open the vessels like completely occluded internal carotid artery by using a stent devices. Paritosh?
Yeah, so I'll come in that. I don't think for a patient of carotid occlusion, in which which is refractory to medical treatment, I do not think that opening up the carotid vessel is the bad idea. We have used a bypass, and that has very high complication rate. And if we can cross with a CTO wire and place a filter, then it's a fairly simple procedure after this to cross the CTO. And I've done this a few times. I have also opened up a basilar artery CTO, but those are very rare patients. But if the patient is refractory to medical treatment and has frequent TIAs or strokes, then apart from bypass, you can go ahead and open up that carotid artery occlusion. And most of these times, the occlusion is in the bulb only. So you can just, once you put a balloon, they open up, and then you can put a stent. So it's as easy as the carotid stenting procedure. But of course, crossing takes time, and you have to use CTO wires. CTO is chronic total occlusion. So you can use the run through or BMW or other wires of the cardiology to cross this. And then once you cross this, then it's not a major problem here. So in selected patients, it's not a bad idea.
Yeah, Paritosh, one of the problems.
These are anecdotal cases.
These are
There is
anecdotal cases, of course.
There is absolutely no literature on that.
Yeah, you can't have data on this. No.
No, not only that. See, the risk of opening of a carotid occlusion, the risks are also there. Hemorrhaging risk is much higher than carotid stenting for severe stenosis. When you open up a occluded artery, the risk, as Dr. Poncha said, I mean, there is really very little evidence to suggest in favor of that. But anecdote, can be there.
So the reason why I am discussing is that, like, suppose we having a complete carotid occlusion and patient is having recurrent symptoms. So again, like, the question is when to take a decision regarding the revascularization. Sir, what is your opinion about that? Patient is in complete carotid occlusion and patient is developing a recurrent TIA or hemodynamic strokes. Then how to go ahead about in these patients? Like, we need to do some imaging and the proof that is a.
Can I answer that, Batu?
Yes, sir.
Yeah. So there are very strict criteria today, because there are many studies, again, like trying to justify revasculation for atherosclerotic carotid occlusion study, and the cause was a negative trial. Then the repeat study was again negative, and but the only study was JET, the Japanese, the carotid study, which was positive for for revasculation. But current indication, which is very highly controlled, is the patient who have second degree hemodynamic compromise. So you need to prove that the patient had perfusion, and usually it's done with Dimox test. I mean, India, you can do that in Dimox. Now we just start. We were previously thinking that only intravenous or parenteral Dimox would be the way to go, but there are many reports now. They are giving 1,000 milligram Dimox by orally and then studying the perfusion deficit. So if you can, best medical management, we've done very few cases I have done it, but if the best medical management, in spite of that patient is symptomatic, and if you can, even if you don't prove the perfusion, because many places is not available now, you can still go ahead and do it. But it has to be neurologist controlled, saying that the patient is still having multiple TIAs or strokes, in spite of all the possible options they have.
Yeah. So we regularly do this sort of a study, and we used to send patient to KM hospital. There was a facility for pre and post Dimox pen. No doubt we don't have a IV Dimox, but the people they are doing with the oral Dimox. Sir, another question to you is like you have mentioned about like in a patient with a contralateral carotid occlusion, like sometime you go over the carotid surgery procedure. So in your decision making for a carotid endarterectomy, the investigation of choice is a DSA or a CT angio?
No, I don't do DSA at all. I
Okay.
don't. The patient mostly have MRI before they come to us, and usually I do two. I do CT angio plus ultrasound, Doppler. Why CTA? CTA gives me the calcium, number one. Number two, the length and the height compared to the vertebral level, which is very, very important for me, because I need to see, because most of the time what we see as the stenosis, usually it is much higher than that. Usually at least half a centimeter, 1 centimeter higher. So I need to expose higher than. So if it is going up to above TC2, I would be very reluctant to do it, because I will be struggling, because I need to go beyond that, right? So I do CT angio. I have never done a DSA unless there is some other indication. Some of the patients have already had DSA and come, but I don't do DSA.
Okay.
And the complete occlusion, the most important test is not this. These are imaging. Most important test is the patient has to go to ENT doctor to see his lower cranial nerves. If he has already lower cranial paresis on one side, and you have a contralateral stenosis you are going to operate, and you develop another lower cranial stenosis, is a disaster for the patient. So please remember to have a lower cranial evaluation if you are going for bilateral disease.
We have another moderator with us, Dr. Pramod Giri. Dr. Pramod, you want to say something? You are busy with this.
No, I just want to put a vote of thanks. That
I
is only
have query.
remaining.
Sir, I have a query.
It was really a fantastic one. I was just listening for almost 1.5 hours. And I
Yeah.
think that many of our concepts with old school concepts have been made clear by Dr. Mishra sir. And of course, Paritosh told us about what exactly where you need to choose the stenting and where do you need to choose the endarterectomy. And I practically believe that since our residency days, we have been taught about endarterectomies only. And the school of thought of Mishra sir that yes, every case is symptomatic case is indication for endarterectomy, except few contraindications are there. So practically speaking, it was a very good webinar today, and we have discussed a very important topic, because being a neurosurgeon also, I'm seeing so many stroke patients nowadays in our OPD, and they're coming with the same questions which Dr. Devra has asked, that it is one-sided block, complete block, other-sided partial block, and the complete block has to be managed, the partial block has to be managed, and then the need of the neurologist, the intervention neurologist, and everyone. And you see that basically the indications are very limited for the stenting, but the one main indication is for the thing is that better than medical management. The question is better than medical management, who is going to decide? And that's why all these stenting procedures are going on very rampantly in our city also. So, practically speaking, endarterectomy is the technique which has been actually getting, what I will say is that the mastery has been lost, and not many people are trained, or the masters have not taken up so much of operative, rather workshops for those. And that's why the intervention people, they are, even the radiologists, intervention radiologists, they are rampantly doing this stenting. So it is very difficult to judge. But yes, as a practicing neurosurgeon who is looking for all the neurosciences patient, the decision making with the today's webinars knowledge, I think that I will be better judged to have some good decisions for those patients. Thank you, Dr. Fali, Dr. Paritosh, and of course, Dr. Mishra, sir, for all your wisdom pearls. And we will be better in our practice because of all this. Thank you, sir.
Thanks. Pramod, Sarang wants to say something.
Let Tarang say
Yeah,
it.
yeah.
I have one query. In the cases of this complete occlusion of carotid, if the bypass has to be done, is it always the high flow bypass, or we can do the STMC bypass also in symptomatic
No,
patients?
no, no. It's never high flow bypass. All the studies are only low flow bypass. The people who are doing high flow bypass is a wrong concept. It's no indication at all. There's no hyper. See, it's a chronic occlusion. It's a ischemia. It's not something suddenly you are taking off a vessel. So high flow bypass is an overkill.
Thank you, sir.
Okay, any questions? If there is no questions,
Yeah,
I
there's
think
a
yeah,
last question now.
yeah, Dr.
So I just want to ask both Dr. Misra and Paritosh, like if they have one side knocked off artery, no flow, the other side very tight stenosis, more than 90%, what will they do? Misra sir, will you go for endarterectomy only, or
Endarterectomy, always endarterectomy. It's no problem. We
so,
monitor we do very simple monitoring. I'll tell you what. We do just EEG monitoring. You can be doing something else also, but we don't do that. I mean, in practice, we do that only EEG monitoring. The only critical factor in my practice, I told that to who are the candidates. If it's a complete occlusion on one side, he has to cardiac status to be good. See, the fact that the patient is all right moving around with a complete occlusion, he's called it said very good. He's somewhere is there. So you need to have occlusion time of 25 minutes, and that's it. I mean, we have a number of cases we have complete occlusion. We have bilateral carotid. I was talking to Batuk about when you are operating on both sides, not one side occlusion, some spontaneous occlusion. When I am operating, I have a few cases where I have operated on both sides. When you are operating on contralateral side, after the first side you've been operated, you have to be very careful about lower canal paresis. There is a little higher risk if there is a complete occlusion one side, because obviously there is a risk of stroke. But I would still advise, if it is accessible to me, it's not very high stenosis, I would prefer endarterectomy. And we have done.
so actually it's very difficult to find the experts like you now, as we are seeing that endarterectomy.
Anita, it is one of the simplest surgery I do.
Yes,
It is
yes, I
one
agree.
of the most
But we
simplest
need to,
surgery.
yeah, we need
Just
to
one
revive
No, sir. No. It is
this
simplest for
surgery
you,
among the
sir. It's
neurosurgeons, the
not
young
for the
No,
neurosurgeons
no,
actually.
surgery is not difficult. It is the support. It is the
Yeah.
number one, the cardiologist has to clear. Number two, the anesthetist to be aware. You need to have a little bit of monitoring, and you have to have protection. You have to have hypertension before you occlude. When you are occluding, post-op, you have to have BP control. These are the three things you need to do. That's it.
There's only
So
one
we
thing.
need to, I think we need to do more workshops on endarterectomies. We are doing
Yeah.
on stenting, but we are not doing on endarterecmies. So I think we should be,
Yeah, Anita,
Yeah.
I just want to say one thing,
yeah,
that for
yeah.
patients who have bilateral severe carotid stenosis, their risk of having a bleed in the postoperative period is much higher. So they need much more monitoring than usual patients. And if you want to do bilateral revascularization, it must be done in a phased manner, around 3 months or something. Otherwise, the risk of bleed by either procedure, by endarterectomy or stenting, is quite high, much higher than the normal population. So that is
So
something.
actually, the data is also
Data.
there.
Yeah.
The stenting has a higher rate of bleed. I actually quoted a paper.
Yeah.
There is a little bit of revasculation in a occluded, one of the occluded contralateral occlusion.
Yeah.
The risk of the bleed is higher. But absolutely, we never do both the carotids anytime. In fact, one of the most famous neurosurgeons, very good friend of ours. I mean, India. He's come many times. He's an Italian neurosurgeon, and he had bilateral carotid disease. He was operated in the same sitting. He remained vegetative before he died.
Yeah, it's not a good idea.
Sir, again, like
Bricolo, I think Paritos, a
Okay, yeah,
neurosurgeon
of
should
course.
know.
I didn't know.
Bricolo is a good friend of mine, very good friend of mine. I know the family, and I know his daughter who had come to us. And this poor fellow, I mean, he's a brilliant neurosurgeon. I don't know how they did it. He's an Italian neurosurgeon. And he had bilateral carotid, same sitting, and he became vegetative. He died. And ultimately, he remained vegetative and died.
sir, a little controversial, but as you mentioned about like for a carotid surgery, we completely occlude the carotid artery for around 25-30 minutes, whatever, like maybe clamping time. So at one end, when we for the aneurysm surgery, we put a clip for maybe 5, 7, 8, 10 minutes. Then we are no.
Hey,
What I mean, what I'm trying to understand from you, we are maybe around so many times with the 3 minutes only we see is a patient having a deficit. So my why I ask you again the previous question regarding the seat angio, because many times we do not know whether patient is having a fatal PCOM or what, because this chronic patient will have a circulation from the vertebral artery. I have seen the only single vertebral artery patient is having an entire circulation.
yeah.
So that was the reason why I was because then suppose I'm having a carotid occlusion on the one side and on the opposite side, I will not have a hesitation on maybe prolonging my clamping because I am sure there is a very good collaterals from the vertebral artery supplying the entire cerebral hemisphere. So that is the reason I just ask about it.
No, absolutely. I mean, absolutely. You need to study the circulation. But what I mean, the difference between intracranial artery occlusion, temporary, and the carotid occlusion is very, very different. You see, the carotid is supplied, I mean, multiple places. Okay. Now, this guy, please understand, this guy is already occluded one side. So he's surviving with that carotid. So how is he surviving? Obviously, there is supply from somewhere else. Okay, so that is the reason he will have and plus if you have a occlusion of MCA as opposed to intracranial carotid artery occlusion, the times are very different. Okay, if you are occluding one a arteriocerebral artery where there is no cross circulation, the times are very different.
It's a
So,
location and the chronicity that makes the difference.
one
Okay.
question, sir.
Yeah. Yeah.
Recently,
Yeah.
actually, I was doing a stenting. This was single artery, and this was high bifurcation. So we just took her for the stenting, and this patient was had previous MI also. On table, this patient had MI, severe stenosis. We could not take the balloon up, even tried to dilate this. We could not take the wire up, and we had to abandon the procedure. So what will you do for this kind where there's very high bifurcation and very tight stenosis, not able to cross it? On table MI, revived, intubated, then recovered. Like, but still she has very tight stenosis and one artery only.
Paritos, I don't do stenting, so I can't answer that question.
Recent MI is one of the contraindications for almost all surgical procedures.
Mhm.
So all these are very preventive. These are preventive procedures for reduction of
Prophylactic,
stent
yes.
risk. And for reduction of stent risk from what? From like 10% over 5 years to 5% over 5 years. So nothing justifies doing anything in a patient who has recent MI. And we should just give medical management for those patients.
So no
I
endarterectomy
just
also, sir.
Anita, anecdotal. I will tell you one. I had a patient who had not carotid, but an aneurysm. I was going for a bypass, high flow bypass for a patient who had a giant aneurysm. Patient had MI on the table. Okay, so and she had a cavernous carotid. I mean, that time was many years back. That time, and he was severely severe pain. So obviously we abandoned the procedure. But her carotid cardiac history was bad, and she continued with this. And after maybe months, she came back, and we did a bypass. So I think what Parito said is an acute thing, and if it is a prophylactic treatment like this, a preventive treatment, you have to be very, very careful about what you are advising.
Thank you. Yes.
Thank you.
Good approach. Yeah.
Thank you. Thank you again. Like, thank you all the speaker, Dr. Phali, Dr. Paritosh Pandey, Dr. Basant Mishra, sir, and our panelists, Dr. Suresh Sankla, sir, Dr. Anita. And Dr. Giri, thank you all. Thank you, Sarah.
Thank you, but thank you.
Committee for
Thank
attending
you.
this work.
Yeah,
Thank
very
you.
nice and very nice
very
coverage
nice.
also. We had a good
Batu and
participants
MCNS,
today.
thank you for inviting us.
Sir,
Thank you, sir.
Thank you, everyone.
Bye-bye.
Good night. Yeah.
Thank
Bye.
you.
good night. Good night.
Bye then.
Thank you.